I have a full presentation, but I thought today I will talk extempore. The reason being people join in between, then I had to repeat. So I will talk extempore to a subject of important subject today. And the subject is that four countries, that is in Europe, have said, so our chair has also joined. So I will then take up the quickly some of the slides which I will show. Let me come back to some quick slides. Where is my presentation? Vaccine information. So I'm going to talk about the subject of vaccine inflammation. Vaccine inflammation means why this subject is being chosen is because of these situations. This subject is to discuss there is a case published in Lancet which talks about a systemic inflammatory response after COVID-19 vaccine. 65-year-old women, she developed high-grade fever and she had D-dimer of 5,267, CRP of 63. She has splenomegaly, she has lymphadenopathy. So this clearly tells us that post-vaccine systemic inflammatory response syndrome, this is something like MIS we see in patients with after COVID-19 in children. This is sparing the lung because the vaccine is not a pulmonary vaccine. So this is one case which has clearly been described in the literature. And then Austria said suspends AstraZeneca COVID-19 vaccine batch after death. Two deaths, one death and one pulmonary embolism. And then came Denmark, Ireland, Norway, and Italy. They have banned use of a batch of AstraZeneca doses as a precaution. And Denmark has done it for 14 days, and they have started this as a 4 countries. In India, we have so far 39 deaths. No details are available, but the early 16 cases, if we see the data, all have been ascribed to cardiovascular brain problems or brain stroke. In every case, the vaccine taken was Covishield. Okay. And then cardiovascular complications, myocardial infarction in particular, and brain stroke has been the most common cause of death. So we come back to now, the basic philosophy, whether European countries banning the vaccine, is it scientific or it is a knee-jerk reaction? So I'll speak for 10 minutes and open for discussion. So COVID-19 is acute, manageable, immunogenic, thrombogenic, inflammatory, contagious, novel viral disease pandemic. Now, what is this vaccine? Vaccine is acute thrombo-inflammatory virus protein. So is this vaccine an acute thrombo-inflammatory viral protein or not? So it is a viral protein is not, is the matter we are discussing. And I say yes, because it is the same protein. It has to be thrombo-inflammatory. Why? Now this is the portion of the virus which you are taking, S1, S2, you are taking to form the spike protein in my body. And let us see, this is the virus, and you have taken this S gene from here, the red portion. So you have to made a recombinant S gene from here. And this S gene, you have added it into a adenovirus, which affects the chimpanzee. So this is a chimpanzee virus with that gene. Remember, this gene has been cut from here, converted into a DNA, double helical. So this is a single helical gene. So you have converted into a double helical gene by reverse transcriptase. So you have converted it like a DNA, which we do it in RT-PCR test. So once you have converted it and put it into the virus, this virus enters my cell. Now, whether this virus is entering my cell or an actual virus is entering my cell doesn't make a difference. Because in an actual virus also, the total RNA is released in the body. In an actual virus, the whole yellow, the whole genome is introduced in my body. Here you are only introducing the red part. Once that enters my body, this red part called DNA is released in the nucleus. It is converted into mRNA, and that mRNA comes out. In natural infection also, mRNA comes out. Okay? When this mRNA comes out, it will make spike protein. So it will only make spike protein, and 3 spike protein will unite together to make a spike. So inside my cell, I have, instead of making a virus, I am making spike proteins and spikes. Okay. Now this cell will start behaving like an infected cell. Like we have a virus infected cell, and here we have a spike infected cell. Now this cell will die ultimately because this is an abnormal cell, and it will have fragments of this spike will come out. They will be identified by antigen presenting cells, and they will attract T cells. You will get a typical Th1 response, production of IL-6, TNF, IL-1 beta, and everything. Macrophages will come back, you will have an LRP response. So whatever response is coming in a natural infection is also coming here. Now here, the virus also, apart from the protein, the virus which has entered my body will also produce a reaction. So there are 2 reactions coming in. One is because of the virus, which is unwanted in the body, and the second is the spike protein. Now and now the B cells will come and they will start producing the antibodies with the help of helper T cells. And these antibodies will do 2 things. They will stop further entry of the virus. So therefore, and then you will have the Th1 response, that is formation of interleukins. Now, what is the difference? Let's talk about what is the, I will come back to the slides again. So what is the difference? There is no difference. The difference is in a vaccine, you have a limited dose of the vaccine, limited dose of the messenger of the DNA you are introducing. This is a one-time entry. So this is a single shot, limited quantity, which does not replicate in my body. So the only difference between this vaccine and the natural infection is, in the natural infection, you have repeated doses. When there are repeated doses, you get infection again and again. Inflammatory, you have persistent inflammatory response. In a vaccine, you have acute inflammatory response, not a persistent inflammatory response. Persistent inflammatory response vaccine. So I always write if I get something new in my mind to make a smaller video. So vaccine is an acute inflammatory response to the viral protein, and natural infection is a persistent inflammatory response to a viral infection. And we all know acute inflammatory response lasts for 4 days. We all know by literature that CRP rises in 4 hours, CRP peaks in 36 hours, CRP comes back to normal by 17 hours, and by 4th day, CRP should be back to normal. So therefore, vaccine-induced Th1 response will be 4 days. So you expect by 4th day, CRP to rise by 3 times. So CRP will rise by 3 times. That is what we expect these people to develop. Now, if that happens in susceptible individuals, it can precipitate. Now, let me again come back to insusceptible individuals. It can precipitate coronary artery disease. It can, now see this patient, 65-year-old female, her D dimer rose to 5,267, which means she had high fibrinogen level, which was expected. So therefore, we do expect a transient procoagulative phase and a transient pro-inflammatory state after vaccine. In a normal person, nothing should happen. But in susceptible individuals, it can precipitate pro-thrombotic state and it can precipitate inflammation state. So if you are normal, you will develop low-grade systemic inflammation and a procoagulative phase, nothing will happen. But if you are already having a pro-inflammatory state or a pro-thrombotic state, this can precipitate thrombosis and inflammation. Now, this explains why did we develop. Now, let me see the pictures. Some of the pictures I want to show. Now, this patient developed, if I can show you, I think. Now, this patient developed angioneurotic edema after 12 hours. This is classical non-IgE complement-mediated complication occurring after 12 hours. These are real patients. This patient, 2 patients yesterday I got who developed herpes zoster after taking the vaccine. This is triggering the underlying virus. So if the body is having a virus inside, this can trigger. This is immunological trigger because of, so there can be a trigger of immunological sickness inside. I saw 2 patients yesterday after the vaccine. This is from New England Journal of Medicine, which talks about a classical type 4 hypersensitivity reaction local. This is self-limiting. This is not of a concern. And we saw this patient yesterday. I saw this patient yesterday. He's a medical doctor and orthopedician. This is called cell-mediated reaction at the local site, which can happen. So which can happen, I saw it yesterday. But what we are talking about is that if you develop a hyperimmune response, it can precipitate transient inflammation. It can cause Bell's palsy, transverse myelitis, meningoencephalitis. It can cause thrombogenicity, which is you can present with MI, you can present with pulmonary embolism, you can present with DVT, and you can have an increased inflammation in the body, which can precipitate appendicitis, you can say cholecystitis, all these things cases. So my answer here is, if you are normal, you may develop pro-inflammatory phase for 4 days. If you are pro-inflammatory, you may go into inflammatory phase lasting for 4 days. If you are pro-inflammatory, you can also go to inflammatory and thrombo-inflammatory state. And if you are pro-thrombotic, you can become thrombotic state. So in susceptible individuals, reactogenic vaccines, remember, I'm talking about the word reactogenic vaccines, can precipitate thrombo-inflammation in susceptible individuals. So I'm not talking about normal low-risk people. So in susceptible individuals, reactogenic vaccines. So in reactogenic vaccines means the vaccines which are more of a la carte and not a buffet. So buffet vaccines are which gives you vaccines against all the parts of the virus, but little bit. And a la carte vaccine is that you are only taking antibodies against the spike protein and you are using the nuclear material. Now DNA will be more reactogenic than RNA compared. So therefore, we are getting more reactions with the DNA vaccine than with the RNA vaccine. So the DNA vaccines will be more reactogenic in the body. This reactogenicity will last for 4 days. These 4 days must be anticipated. So I feel the reaction by the Europe is a knee-jerk reaction of stopping the virus. They must anticipate that these complications can come, and therefore all susceptible individuals, if they have been given the vaccine, take care of those 4 days by giving them aspirin to prevent procoagulation, statin if they have high cholesterol, and give them colchicine if their CRP is more than 1. If they are pre-inflammatory, give them colchicine. If they are prothrombotic, give them a statin and aspirin. Give it, and if you give it and control those 4 days, this will not happen. So all those cases who are developing acute MI, acute pulmonary embolism and dying is what we expected. There is nothing unexpected. From political point of view, they will say not related to vaccine, which is correct, because reactogenicity can happen with any vaccine. And we have seen in the past, even with flu vaccine, people getting deaths because flu is also a reactogenic vaccine. So I only want to say is that you are converting an unpredictable pulmonary COVID into a predictable muscle COVID by giving a vaccine. Reactogenicity there is unpredictable. Here it is predictable. So from unpredictable to predictable reactogenicity. And if you do that from unpredictable to predictable reactogenicity, you can prevent. So every death is preventable after vaccine if you follow this principle. Over to the chair.
Thank you, President. Can you hear me?
Yes, sir.
Thank you, President, for your comments. It is indeed always a pleasure to tune into our Saturday Zoom talk. What is fascinating is that the mechanism of the AstraZeneca vaccine seems to be slightly have some slight differences between that and those of the Moderna and Pfizer vaccines. Is that right, President?
One is this is a DNA vaccine, they are an RNA vaccine, so therefore they should be more reactogenic. So we need to take precautions. Instead of banning the vaccine, we must anticipate these are reactogenic vaccines. Yes, go ahead, Dr. Chung. So his voice is not coming. So we can go ahead with other people to talk about it, to talk about their shares. Dr. Chaudhary, what are your experiences of vaccination in Bangladesh?
Yeah, Bangladesh actually is observing actually not such serious reactions. Actually, it's not yet reported. So there are a lot of vaccinations are going on, and people are coming up. So this is good. But the thing is that worry is infection number of cases are increasing day by day, and this is worrying actually. And we are not sure whether the B117 is spreading, because the authorities telling that one was detected early in January 5, but they're telling no, it's not that sort of this spread from this year, B117. So people are suspecting and should go more this year testing actually, and seeing what type of virus and what type of mutations are going on here. That is actually worrying here now.
Hong Kong, Dr. Chan.
Yes, thank you, Mr. President, and thank you very much for the very interesting and enlightening talk just now. And so in Hong Kong, we are now giving vaccines for 2 weeks. First, the China manufactured coronavac from the Sinovac, all right, is a killed virus. And for the recent 5 days, we also have started the vaccination with BioNTech, the mRNA vaccine. So we had also ordered the AstraZeneca Oxford, the DNA virus, but it won't be available until, say, summertime. So first of all, for the past 2 weeks of vaccination with this killed virus, the Sinovac, it's quite unfortunate that in Hong Kong, people started worrying about the deaths after vaccination with the Sinovac. So there have been 5 deaths so far after vaccination with about, I guess, about a little bit more than 100,000 doses. Just a very small number. But then already 5 had died after the vaccinations. Of course, our experts and the authorities had reassured that these deaths are not related to the vaccines directly. And in fact, not excessive about the usual mortality rate in Hong Kong, dying from coronary heart disease, strokes, etc. So they said it's incidental. But unfortunately, the psyche of the citizens are mentally quite. They were just horrified by such news reporting almost every day about these so-called adverse events and also deaths after vaccinations. So I think it is just like when it's initially rolled out in Norway, 33 elderly died in Norway. And then now in Europe, the incidence of thrombo-embolic events after AstraZeneca. So of course, these are knee-jerk reactions. And so we can see that in Israel, people are not affected by these news at all. So I suppose that, of course, Mr. President, today you had already enlightened us, and the EU countries should not have the knee-jerk reactions to halt the vaccination program with AstraZeneca. And so I think Australia, Korea, India, many countries are also giving AstraZeneca. And if we have the precautionary measures of identifying those high-risk patients and giving them the medication of aspirin and statin, etc., beforehand, so these adverse events probably could be prevented. And I suppose the same is with the BioNTech and Sinovac intake in Hong Kong. We have one Bell's palsy, and that's for sure. It's most likely an adverse event from the vaccine. And it's from the Sinovac, the killed vaccine, not from the BioNTech yet. And also because of the the people are erring on the safe side. So they tend to go to the killed vaccine injection centers rather than going to the BioNTech, because they are afraid that this is, after all, a new technology, less predictable about the side effects. And so people tend to go to the centers providing the killed vaccine rather than being so-called guinea pigs to receive the BioNTech. So, but anyway, in Hong Kong, so the number of people have been going to the vaccination center have been dropping a lot because of the people are fearing about the side effect and the mortality rate after vaccinations. So now people have some hesitation to go for the vaccination, and all those appointments are half filled only. That is, it's quite a waste of the manpower. And in fact, it's quite worrying for BioNTech because we need to dilute the BioNTech before vaccination and defreezing and then diluting. And after dilution, it could not wait for half a day to finish that. So it could be a waste of the vaccines if half of the people had not turned up for the vaccination. So it's something that we need to deal with. And of course, now, just for 3 days, Hong Kong had a big cluster of infection of COVID-19, again, from the gym, a high-class gym had some super spreader there. And it's worrying about the inauguration of the 5th wave, you know. So, and also we had just a few people coming into Hong Kong, our citizens coming from abroad, had the virus of the mutant virus, UK one, the 117, a few only. And for the South African mutant variant, only 1 or 2. So I think the Department of Health must be extra vigilant in testing those coming back to Hong Kong, and also in quarantining and restricting trace contact of these incoming patients with the mutant variants. So far, it's good that at least there is no spread in Hong Kong of these mutant genes. But then we are really worrying about the 5th wave, and then the people hesitation in getting the vaccination. Thank you.
I just want to add one thing that Alvin raised one issue, that the incidence of complications is same in pre-COVID and a post-COVID era. But remember, pre-COVID is health unaware society. Post-COVID is 100% health aware society. Everybody is so much knowledgeable. So even these 5 deaths should have been prevented. So we can't compare an uneducated, health unaware society with a COVID era. In a COVID era, the incidence of all the diseases have gone down. Then similarly, MI, thrombotic disorders should go down. If it is a preventable death, we should be able to prevent it. So from my point of view, all thrombo-inflammatory disorders, including MI, pulmonary embolism, we should be able to predict and prevent it.
In a way, Mr. President.
I can give you one example.
Yes.
I was diagnosed with Crohn's disease. Okay. This is pro-thrombotic, pro-inflammatory. This is thrombo-inflammatory disease. It is pro-thrombotic. And I never even read about it. It is pro-thrombotic, and I developed pulmonary embolism. So if I would have been alerted at that time, this is pro-thrombotic, I would have prevented pulmonary embolism in myself. That's what I'm talking today. Today, once we know that this vaccine is pro-thrombotic, evaluate yourself, am I pro-thrombotic? That's it. This is an opportunity for the people to be aware that this virus can precipitate. It's a trigger for inflammation. It's a trigger for thrombosis. Even pollution is. even high grade of pollution is also pro-inflammatory and pro-thrombotic. So once you know it is a trigger, just prevent it for 4 days.
Exactly. Thank you, Mr. President. In fact, I echo your view.
Yes.
However, first of all, many of the people going to the vaccination center, they don't have the medical history at all. And many people in Hong Kong still have not had the habit of having a family doctor. Well, if all our citizens have a personal family doctor, then they will know whether they have such a prothrombotic disease underlying, and then they should have the pre-medication. So unless we are advising all vaccinees to have pre-medication beforehand, otherwise I think it should be selective. That is, those with a history of such diseases predisposing to a higher risk of inflammatory and reactogenic thromboembolic disease, they should have the aspirin, colchicine, statin, etc. Unless we are advising all citizens to take these medicines beforehand, then we are going to select those who are higher risk with the family history, with the family doctor attending them, giving the advice. However, in Hong Kong, people are just shopping around and people just don't have the habit of having family doctors, personal family doctors. So we need to upgrade policies in Hong Kong as well from the citizens. Yeah, that's what we are going to advise the government. In fact, thank you very much, Mr. President. And also, I'd like to ask you, Mr. President. So you had highlighted that the AstraZeneca, the DNA vaccine, is more reactogenic than the mRNA vaccine. So what about the killed vaccines? What is the grading of their risk?
We don't know. We only know is the most reactogenic vaccine is shingles vaccine.
Yes.
The most reactogenic. Then they said that mRNA vaccine is the second most reactogenic.
Oh.
Now we are finding that DNA vaccine may be more reactogenic than mRNA. This is our anecdotal observation and logic base.
Yes.
So the literature says mRNA is number 2 reactogenic, but I feel because you have double reactions occurring, conversion of DNA into RNA, therefore DNA viruses will be more reactogenic.
Yes. So just please enlighten us. What is shingle virus? Is that is a DNA vaccine?
Dr. Agarwal, can I just...
A recombinant vaccine, totally recombinant vaccine.
Recombinant.
Yes, recombinant vaccines, totally lab-made vaccine. It's neither kit vaccine nor a live vaccine. It's a total, anything which is recombinant will be more reactogenic.
I see. Thank you. Thank you.
Dr. Agarwal, just an observation. Actually, my daughter was vaccinated some days back, and according to advice, actually, because she was allergic, so I gave her the pre-medical. She is a doctor also. So, but she developed fever, low grade, of course, and the myalgia for 2 to 3 days like that. So it was not severe, but anyhow.
So let's see, fever, myalgia, interferon.
To the higher authorities.
No, Jamal, what I'm saying is fever and myalgia is a gamma interferon inflammatory response, which is linked to IgG and IgM production. Allergy is IgE response. So she prevented all allergic manifestations, but allergic pre-medication will not prevent inflammation because inflammation is involving other cells in the body. So it's a good sign if she develops myalgia and fever. That is because of gamma interferon and TNF alpha, which means she's producing antibodies. So that's a good sign. Mari, Angelic.
We are discussing good.
Thank you.
Very good points actually we're discussing actually, and the WHO and others actually they are not suggesting all these things.
Yes.
So can we just give us some suggestions to those bodies actually from this forum?
I totally believe that treatment is a domain of a practicing doctor, not the domain of WHO or ICMR or Ministry of Health. They can't tell us how to, they can come back with broad guidelines. The broad guidelines is that rest of the treatment has to be decided by the medical bodies. Therefore, I'm bringing these discussions in CMAAO for a consensus statement. WHO will never say what to give, what not to give, because that's not their job. Their job is globally. So what we are making a statement today is that in susceptible individuals, so we are using the word insusceptible high-risk individuals, if they are pro-inflammatory and pro-thrombotic, prevent them. Prevent formation of inflammation and thrombosis. That's it. That section, because WHO cannot come back with each section, that what we should do in pregnancy, what we should do in others. I think it has to be decided by the bodies.
Morning. Following this conversation with great interest, South Africa, we only have so far 200,000 people vaccinated. We don't have the AstraZeneca vaccine, so I can't comment on that. But it makes sense that if you know that you may be pre-thrombotic, to take aspirin, although I don't think the average person out there will understand it. But so far with the Johnson & Johnson, we had one severe reaction, and that was treated immediately. And the patient was in hospital one day and discharged. No further side effects. So adrenaline was immediately given, and that's it. So far, you know, as you have said, the reactogenicity regarding myalgia, a bit of a fever, low-grade fever, body aches and pains, seems to be the most common side effects for a day or two with Johnson & Johnson. But so far we're quite happy with what happened. Thanks.
Yes, excuse me, Angelique. So in Brazil, you are also having the Sinovac, CoronaVac, is that right?
No, we South Africa. We only have Johnson & Johnson. We are going to get Pfizer in the next 2 or 3 weeks.
I heard that CoronaVac of the Sinovac from China were having their 3rd phase trial in Brazil. And that's why they also, the Brazil government had also approved the use of Sinovac, CoronaVac in Brazil. So that's not true?
I cannot comment on Brazil. I'm not sure what happened in Brazil.
So you're in South Africa,
yeah,
sorry.
Yeah. So it
yeah,
would be
I'm mistaken, sorry.
No, that's fine. It would be interesting to hear what our Brazilian colleagues is saying.
Yeah, so in South Africa, you are having BioNTech rather than AstraZeneca right now. Is that because you had suspended the AstraZeneca injections in South Africa? That's what I heard, I thought, 2 weeks ago.
Yes, you are absolutely right. We are only looking at, we are doing the Johnson & Johnson.
Johnson & Johnson.
Yes, yeah. Currently, and there will be Pfizer coming in within the next 2 or 3 weeks. I think the Pfizer vaccine, this is a good vaccine, but you know, South Africa is quite hot.
Yes.
Our infrastructure is not so good. So I'm not so sure about the storage. I think we're going to have trouble with the storage. But you know, that's what's going to come into the country. So let's see what happens. We will understand within the next 6 weeks how that's played out. But I'm not also so sure about, I'm not sure whether the colleagues here can give a bit more advice, that America also struggled with the storage with ice. So maybe if you can give us some, you know, background on what we should watch out with the storage. We are not as good as Japan or the other countries infrastructure. So I would be interesting to know. Thanks.
Yes. In Hong Kong, I think in Hong Kong, the situation is similar to Singapore. We are also a hot place, but then I think Singapore must be very experienced in this matter because they have been rolling out the BioNTech Pfizer vaccine for 1 or 2 months and very successful. In Hong Kong, we heard that they said that the vaccine could survive even in negative 20 degrees Celsius for 1 or 2 days. Although it was said in the insert that it should be stored at negative 70 degrees Celsius. But in Hong Kong, the government still would persist to store it at negative 70 degrees Celsius. And Hong Kong is only a city and it's easier to manage than a big country like South Africa, I think. What about in India, Dr. Agaro? How do you manage the storage temperature problem in India for the?
Dr. Pillai from let Dr. Pillai speak out. Dr. Pillai, Dr. Mathanda Pillai, his center is also a vaccine giving center.
Thank you, KK. Our cold chain is perfect because the vaccine that we are using has to be stored, say, 4 to 8 degrees centigrade. So that's what we usually use for other polio and rest of the vaccine. So that system is very perfect in India. Regarding the side effects and mortality associated with Astra vaccine, which obviously we are using in India also, we have used it almost for 1.5 crores of people, and death directly related to vaccine use has not occurred in India. But the Australian case where 2 people, one had a cerebral thrombosis and another myocardial event, how far it is directly related to vaccine, still more studies and investigations are required. But then as a precautionary measure, that batch of vaccine is not is withdrawn from the market, and that is normally what is usually done when there is a drug reaction. But whether the whole vaccine has to be stopped, more information has to come in. But already, at least from 10 countries, particularly in the Russian Asian area, have stopped using the vaccine. This has happened with AstraZeneca vaccine, that is the adenovirus, live adenovirus combined with modern technology. And but the studies that is available in India shows that the dead virus vaccine, that is Covaxin, is much more reactogenic than this AstraZeneca vaccine. So that is the information that we have. I feel that more studies are required before we can come into any conclusion, particularly a public health program of such a massive dimension. Whenever more steps are being taken, it has to be on the basis of accurate, deliberate studies, rather than casually we cannot stop a process or restart a process. But whatever has been briefed today by KK is very informative, and further studies in this area definitely are required before we can come to a conclusion as to what precautions are to be taken. Already in India, we have a setup where at least for Covaxin, a medical doctor has to certify regarding the comorbidities the patient has got. Maybe that format can be applied to all people who are getting vaccine. A medical certificate as to their comorbidities and appropriate preventive measures may also be incorporated. But then this sort of a decision has to come even at a policy decision, even at the WHO level. That is what I strongly feel. Meanwhile, whatever precautions have been suggested today definitely can be followed. But then aspirin, use of aspirin as a precaution It is an antiplatelet, but here the issue is anti-thrombotic drugs, whether they can be casually sort of started as a precaution. Aspirin definitely can be done, but aspirin's role is limited only to the extent of an antiplatelet drug. So there again, little more application and study may be required. Thank you.
So I want to bring this this mantra for today, this sutra or this statement of insusceptible, high risk. Remember, insusceptible. We are not talking about general population. And insusceptible, we are not talking about low risk or moderate risk. Insusceptible, high risk, pro-inflammatory or pro-coagulative or pro-coagulative individuals, reactogenic vaccines can trigger transient thrombo-inflammation lasting first 4 days. Am I correct? This answers all the queries. Insusceptible, high risk, pro-inflammatory and or pro-coagulative individuals, reactogenic vaccines can trigger transient thromboinflammation lasting first 4 days, first few days, few bracket में 4 days. Chair, Dr. Chong,
Yes, President.
am I correct in making?
I think it's a good mantra.
Dr. Agarwal, does it support?
Yes,
does it
I
support
believe so.
does it support the this evidence found actually in those cases in Sweden and Norway like that?
No,
Because those people actually
it
by having this.
No, it explains all the complications. Transient inflammation can precipitate Bell's palsy. Transient inflammation can precipitate herpes zoster. But transient thrombosis can precipitate MI, can precipitate clots. The only thing is first 4 days you have to prevent. That's it. You have to anticipate and prevent.
No, I'm just asking that those cases actually were pro-inflammatory and also pro-coagulative or not. Those cases actually, that's
thrombosis will always come.
Whether they have the history of that.
Pro-inflammation thrombosis will always come after inflammation. So they have only mentioned one developed pulmonary embolism and one died. And then they said 22 patients in total have developed clotting manifestations. There are 22 cases in Europe of clotting manifestations. And because of that, these 4 countries said we are stopping it. But stopping it is not the answer. The answer is this statement. This is what I'm saying. You see, in any way, forget about this vaccine. All population must consider this because reactogenic vaccines can trigger, is one of the trigger. There are so many other triggers. So if you take this in our clinical practice, we will be able to shorten the incidence of heart attack to a greater extent. This will give us an opportunity to pick up every disease. Chair.
Yeah. President, I agree with your statement. I think that, can you hear me?
Yes, yes. Yes, I can.
Yes, I think it's a very good conceptual understanding of what's happening globally. And it's interesting that what you said about the AstraZeneca vaccine is that it's actually a DNA, it's a double helix DNA that is brought in by the chimpanzee virus into the muscle cells. Now, we know that from the Pfizer and the Moderna messenger RNA vaccines, that the messenger RNA is transported into the muscle cells and is destroyed probably in 2 to 48 hours. Now, I gather from, or I infer from what you're telling us that this double helix DNA may last a lot longer and generate more messenger RNA in the skeletal muscle cells. Is that correct?
That I'm not saying that it may last longer, but it will be more reactogenicity.
Yes.
The total duration is 4 days. It's up to 4 days. So I'll make it up to 4 days.
So
Well,
one possible mechanism is that the double helix DNA actually persists longer and generates much more messenger RNA.
He's saying it requires more steps in the cell.
Yeah.
Therefore, it may be more reactogenic because it is involving first converting into entering the nucleus, entering into making RNA, then coming out. So it is taking more time in the cell. So therefore, the cell will have more inflammation.
Yes.
The time duration within the cell is longer here because it is first has to enter the cell, enter the nucleus, enter from the nucleus to make a messenger RNA, from RNA to break proteins. It will take longer time than the RNA itself.
That's right.
Therefore, reactogenicity time will be more.
So this vaccine has caused more, in a way, has a greater capacity to cause more thrombo-inflammation. Yeah.
This is a logic. We are talking about the logic.
Yeah.
The logic taken with the evidences, anecdotal cases. So we are seeing anecdotal cases of inflammation, and there is a logic. Therefore, in a pandemic-like situation, we don't wait. We work on anecdotal examples and the logic.
Yes. In no man's land, actually, we have to do empirical judgments and treatments. The other thing is just to share the Singapore experience. So we do not have AstraZeneca yet. We have Pfizer, Moderna, and Sinovac. In fact, we hear that Sinovac is going to be approved here in Singapore. And the vaccine rollout in Singapore will be, there are centers, which I brought my mother-in-law yesterday for her Pfizer vaccine yesterday. And these centers can process up to 2,000 a day. So with a full capacity of all centers in Singapore, we're looking at 60 to 70,000 vaccine administered daily, if we have a good supply, and complete the population within about 3 months. So that is what they are on track to do. I spoke to the staff running the vaccine center yesterday. They had 1,200 yesterday. We went there in the evening. So they had almost done for the day. And it's interesting that we haven't had much problems with thrombo-inflammatory cases or deaths at the moment. There, however, has been a new guideline issued yesterday of how to address who should be vaccinated. So previous guidelines were a little bit too tight and led to a lot of rejections. And of course, amounting to more hesitancy because patients showed up at a vaccine center and were rejected by the staff. For example, if they had NSAID angioedema, they were rejected. So for example, if the patient said, I had taken aspirin and I have swelling of the eyes, they were rejected. And the new guideline has said now that please do not reject these people unless they actually have anaphylaxis. So we have some vaccine hesitancy because of the advice previously given to these patients. But my patients who have come in to see me, I have pre-medicated them, especially those who have asthma, allergy, rhinitis, and eczema, and those with high CRPs. So we've actually pre-medicated them, and they seem to be, so far in my practice, seems to be fine. My staff who had the facial palsy has been asked to defer. I spoke to our Director of Medical Services, and she's been asked to defer her second shot, her second vaccine by 2 weeks. They still, rightly so, as you mentioned before, think that the Bell's palsy is not directly causative, but as what you said, is actually triggered by the thrombosis and the thrombotic state and the inflammatory state. That's all I have to say right now. Thank you.
Can I say something about the Malaysian perspective, please?
Yes, please.
Okay, here in Malaysia, they only have the Pfizer vaccine. And what they've done is they've started off with the frontliners from the public sector. The public sector, all of them are being vaccinated. The second is the police and the army personnel. And the general practitioners will be the next. They've actually started with the general practitioners in the private sector and also the specialists. Many of the states have started, and so far there has been no any particular reaction. I mean, the normal reactions like pain and soreness and inflammation, that's about all that has been there. There are talks about the Sinovac that is going to be brought in, but we're still waiting for that. So far, things are quite good. So that is the Malaysian perspective.
Chair.
Excellent. Thank you.
So, Chair, I want to show you one slide.
What?
Yes.
I want this also to be, so this is summarizing what I said. So I am calling it as a muscle COVID versus lung COVID. So one is a vaccine COVID, one is the COVID disease. So there is a spike protein in muscle COVID, and there are all the proteins in the disease. Now, a spike protein, except in a kill vaccine. It is non-pulmonary, that is pulmonary. Dose of the virus. It is a fixed dose, that is a variable dose. It is DNA that contains RNA. So I'm talking about vaccine which are like Covishield, which is AstraZeneca. This is acute inflammation which causes persistent inflammation. The response is predictable. There the response is unpredictable. Here the dose is repetitive. The replicable is inside the cell, and repetitive is patient is maybe having a repetitive dose if he's in a hospital or an atmosphere where the virus is there. It is a transient inflammation, that is a persistent inflammation. It is pro-inflammatory and pro-thrombotic, and that is highly thrombotic and inflammatory. Am I right?
Well done, President. Good summary.
So this will explain us that vaccine is also a controlled virus disease.
Mr. President, is it only DNA or the right DNA or RNA?
This is DNA.
Oh, Covishield. You have mentioned Covishield also.
This is controlled.
I recall, President, I also recall you telling us that these animal viruses, like the chimpanzee viruses, have a high incidence of neurological complications.
Yes, when we saw transverse myelitis. When we talked about it, when we talked about transverse myelitis, this virus causes transverse myelitis in chimpanzee. So it is expected.
Ah.
And then one should also not forget that in this virus, you are also introducing another virus in the body apart from, you are having two. You are adding the chimpanzee virus, adenovirus, plus coronavirus protein. So it's a fixed dose combination of a drug. It is an FDC. It is not going to be a non-FDC. So therefore, it has to be more reactogenic. It is expected. It's an FDC, like a fixed dose combination of two drugs. You are having two viruses together. So how can you expect it to be less reactogenic? They will also compete with each other in reactogenicity.
Yes. Fascinating, fascinating. So in retrospect, the messenger RNA vaccines seem to be a little bit more elegant.
No,
you know what I mean.
What I am trying to say, whichever vaccine you take doesn't matter.
Yeah.
As a clinician, be aware how to handle a particular type of a vaccine. There comes our role as a doctor.
Yes.
Policymaker cannot come with the clinical acumen, because if they have so much of clinical acumen, they will not have a time to make the policies. And we have so much time for the clinical work, we have no time to make policies. So therefore, everybody has a distinguished role. So we are talking about clinical logic. In a pandemic, only logic works. You can't wait for people to die and then come back with an evidence. So the logic works. So I've only presented a logic with those two slides And these two slides, I will take it up as a CMAAO summary. And when I will start putting it into my COVID Times daily presentation as a COVID sutras from CMAAO.
Excellent.
But Pfizer Moderna actually was showing more anaphylaxis. You remember? You got the point? We have.
I think the anaphylaxis in the Pfizer and the
Yes.
Moderna vaccine is due to
The Moderna
the
was
liposome. The liposome and the PEG. Yeah.
All viruses are reactogenic. Prevent that anticipate and prevent. That's all. So if anybody else is left, then Dr. Mathinda is done. Ravi has spoken. Then Anjali. Yes, Mari.
Yes,
Mari,
in-
was.
Mari and
Yeah.
Oh yeah.
Thank you. Thank you very much for all the time. And in Japan, the vaccination has been started, and about 70,000 people have got the shot. And about 25 are reported as anaphylactic reaction. But among them, 17 cases is looking at the detail, and it shows the only 2 cases is classified the level 1. And also the one death after shot has been reported, and she was her 60s, and she died after 3 days after got the shot, given the shot. So maybe she had some kind of thrombo-inflammation disease, but we are not sure yet. Soon detail will be released. Thank you very much.
Thank you, Marie. And it's interesting because I recall reading that in healthy blood donors, 25 to 42% of them had PEG antibodies. So because PEG is actually in the liposome in the Pfizer vaccine, is found in food, processed food, is found in sunblock, cosmetics, shampoo, soaps, etc. So about 25 to 42%.
So the sister of PEG is polysorbate 80, which is present in all other vaccines. So remember that polysorbate 80, which is a sister concern of polyethylene glycol, is present in refresh triers. It is present in many other vaccines. It is present in many disinfectants. So therefore, remember either PEG or polysorbate 80.
So, President, I'm thinking to myself that if Pfizer comes up with a booster, I may be a bit hesitant about taking it because there'll be a 3rd shot with PEG in it.
Yes.
Yeah, and I'm thinking personally that if I needed a booster, I will go for a kill vaccine, like Sinovac.
You want to go for you can go for a kill vaccine, or you can still go for a Pfizer with a scratch test.
With a scratch test, yes. Because I'm kind of worried about the 3rd or 4th shot with the PEG.
So can we, let me see if I can have a workshop on how to do a scratch test and how to do a terminal test. That can be done so that everybody can spread that video to their concerning countries.
Excellent.
So we can close the meeting. Can you sum up?
Yes, please.
If anybody is done, the Prakash is left from Nepal.
Yeah. Dear Chair and dear President, in Nepal, we are using the Covishield vaccine only, and almost 5% population are vaccinated. Till now, there is no so serious complication and the death reported. And government of Nepal has gave the emergency permission for the Covishield and Sinopharm because the Chinese government want to donate the Sinopharm vaccine, but till now not received by Nepal. That's why now we are in the community that is more than 65-year-old risk groups are getting vaccinated till by 2 days. And till now, we are thinking that vaccine Covishield is doing well. Just I want to think that.
Thank you.
I want to add only one point is in India now Covaxin has been taken out of the trial mode. Now it is EUA mode. That means the trial mode is over,
Yeah.
and Government of India has recognized it as under a non-trial mode. Now it is a regular vaccine approved in India, not in a trial mode. Up till now, because it was in a trial mode, government was not exporting it and donating it to other countries. Now Covaxin will also be available slowly in international market also.
Yeah, in Nepal also, because the Covishield, the private company, they can import also, and they can sell, so that if the person want to pay and get vaccinated, that will be also allowed by 5 or 7 days.
Okay, good. So can I have the summary now?
Yes, thank you, President, always for that very illuminating lesson that you have prepared for us. And we thank you very much for all your hard work in the last, I've lost track, maybe 45 weeks or 46 weeks. and it's this armchair immunology series is incredible.
It is 51st meeting.
Oh, 51st, okay. And this series of 51 armchair immunology lessons is incredible. Really, really brought our immunology up to speed, which is actually critical for this time, although we may laugh about it. So thank you all for your updates for the various countries. It's good to see that the wave of vaccinations is spreading across Asia as we speak, and that more and more countries are reporting good uptakes and good rates of vaccination with less or minimal vaccine hesitancy. It's a good sign that we can finally see some light at the end of a tunnel for all of us, and for this year of devastation that this virus has brought to this part of the world. But yet we always look at it on the bright side. There are always a silver lining to everything. I think the world has changed in many, many ways, and CMAAO, us coming together for 51 weeks in a row, is perhaps one of these silver linings. I thank you all, and I look forward to our next meeting next Saturday.
Thank you, everyone.
Thank you. Thank you.
Bye.
Thank you very much. Bye now.